So thank you, first of all, very much, the organizers for inviting me here in this honored task of being a host of this really interesting discussion regarding OCT. These are my disclosures, and they're not really relevant to the topic. So actually, we heard a lot also in the previous theme, in the previous discussion, regarding useful tools and useful biomarkers to follow up our patients. And I won't go into detail regarding this, and I will really go directly into the theme, what is OCT, but I just wanted to mention, also following up to the previous talk, what is actually the most important unmet need for you as neurologists now at following up the patients. And I think regarding the inflammatory changes, the activity of our patients, we are not that bad because we have the relapses and we examine them, and we also have the MRI with the new lesions or with the active lesions, and these are really good measures of activity. But where we really have the unmet need is to have measures that fracture disability and progression, and especially relatively early, so before our patients are already severely disabled. And we know we have MRI atrophy from the studies, and this is really a very good measure, but the problem is how to really implement it in the clinical practice. There we have the problem, that we rarely do it individually at a patient level. So I guess that at the end, the prominent speakers will concentrate on the potential role of OCT as this biomarker, so of disability and probably early at the disease onset. And my role will be, as I said, to introduce you to OCT and what are the typical findings in multiple sclerosis. So we start with the question, what is OCT? So this abbreviation stands for optical coherence tomography. Why optical? Because it is a technique, it is a medical imaging technique that uses light, laser. And why tomography? Because we don't just get two-dimensional pictures of the retina, but we get slices. So it is a technique that makes cross-sectional images, a little bit similarly to the MRI. So we get slices of tissue, and of the retina in this case. And why coherence? This is a little bit difficult to explain because it has to do a lot with light and physics. But if we simplified it, you can imagine that we send light to the retina of our patients. Only a part of this comes back to us and is transferred into signal, but this signal depends on the structure of the tissue. So, because an image is like 1,000 words, you can see what I already told you, that with OCT we have actually images that are slices, tomograms. So we have actually the third dimension of the retina. We have the thickness of the retina, which is really measured with high resolution. And what I meant with the different signal of different layers, you can see actually here in the retina of an eye, that we have really different grays, different scales of gray or even white for the different layers of the retina. And this technique has really a very high resolution. And what interests us actually as neurologists, so I guess that all of you are neurologists and not ophthalmologists, so what are the interesting parts of the retina? Why do we even bother with OCT? And the two most different parts are the macula and the area around the optic disc. And why, I will explain you in this slide. Because these areas have actually structures that are part of the central nervous system. So we have here you can see again the eye, and you can imagine here the retina should be the yellow, and we have again macula and the optic disc, and then back more posteriorly the optic nerve. And if you see it now in a big magnification, you can see again the macula with the characteristic form, and you see here the ganglion cells relatively up to the surface. These are cells that are neurons. These are actually the first order neurons of the visual pathway. And they are axons that you can see here in yellow that we often call retinal nerve fibers. They are the ones that are here gathered around the optic disc. Here they are very thick because they're all together in order to build the optic nerve. So what can we really see then with this OCT, with this tomography? On one hand, we can make the slice in the location of the macula, and you can again here appreciate the different layers, and you can see also the ganglion cell layer. So we could have a measure of the thickness of this layer with the ganglion cells. And if we make now an image around our optic disc, so in this part here, imagine to cut this here with a kind of circle, and then we open this ring, you can also have a measure of the thickness of this retinal nerve fiber layer, which is often referred as RNFL. So, what are the typical findings regarding these two layers, the ganglion cell layer and the RNFL in MS patients? If we want to summarize this with one sentence, we can say the typical finding is that they are thinner than in non-MS eyes. So we have loss of ganglion cell, of neurons, and of the nerve fibers of the axons. And here is just an example of a right MS eye where you can see again this OCT image around the optic disc, and we measure the thickness here between the two red lines, and you can see here a red color, which means something is below the normal values, and this is actually the thickness of the retinal nerve fiber layer, especially in this part here in the middle, which corresponds to the temporal part of the layers. This is what we also know for decades or more, this temporal atrophy of the fibers, the temporal pallor that we also see with the fundoscopic examination. So this is a typical finding in MS, and similarly to this, we can also appreciate often this thinning of the ganglion cell layer, which has also been even showed histologically. Actually, also for many, many years this was known, but because we didn't have such a technique to really appreciate it in vivo, we just have ignored it for some decades. And this has also been shown in studies that indeed, so this is a finding that we cannot ignore. This is true that the MS eyes are thinner. So if you see here again the RNFL thickness and the thickness of the ganglion cell layer, we see that in the MS eyes, which is the darker color, we have a statistically significant difference compared to control eyes. We have this thinning. So actually the question is, I won't go into detail because I'm sure that the prominent speakers will explain this for you, but the question is, are these changes that we see in the eyes only interest us because eye is often, and the retina is often a part of inflammation in MS? So is this interesting only from the view of a neuro-ophthalmologist or from the view of the eye inflammation? And this is exactly the debate. So are these changes also related to brain changes? And I won't take now a position here. I just wanted to mention that this is a hot discussion, that indeed the eye is a window to the brain, so that the changes that we measure in the retina might reflect changes that we have in the brain, especially in the visual pathway, in the posterior visual pathway. So there is this theory of the transsynaptic axonal degeneration, which says that if we have a damage here in the optic nerve and loss of axons and neurons here, then this shows a kind of domino effect. So this leads to atrophy or to loss of axons and neurons in the thalamus and then also in the visual cortex. And the other way around, if we have damage, lesions, and loss of axons here in the optic radiations and the visual cortex, this can also cause an atrophy in the retina. And according to this paper here, they go even one step further, and they say it's not only that the atrophy in the retina is associated with an atrophy of the visual cortex, but it might also tell us something about the atrophy in the entire brain, so about neuroaxonal loss in the entire brain. So this is actually, let's say, the hot topic of discussion regarding OCT, and in which way can it really reflect also damage in the entire central nervous system. And this is actually also one of the questions that came into my mind when I heard that I will be the host of this talk. So what kind of open questions are there here to discuss about? I think one of them is this. Is this atrophy that we see in the retina, does this reflect only a damage of the visual pathway, or is it really a good biomarker for a damage in the entire nervous system, in the brain and even in the spinal cord? Some other questions, at least from my point of view, could be, do we have only reflection of neuroaxonal loss, of neurodegeneration, or also of inflammation? It has been also proposed that some other layers might be more indicating of inflammatory changes in MS patients. Some other interesting aspects, for example, what do we do if we have many patients who have optic neuritis and others who do not? And this could be a problem because in optic neuritis we have unproportionally large damage. So what I showed you with this thinning, this is much, much more if we have optic neuritis. So how do we treat these patients, they cannot be directly compared with patients that did not have optic neuritis. Or here, even going one step further, similarly to the previous speaker, what about the non-MS-associated changes in progressive older patients who have also a thinning of their retinal nerve fibers because of glaucoma or some other conditions? How do we treat this problem? Also, how sensitive is OCT to change? Does it really show? So cross-sectionally we see these differences, but what about longitudinal change? And of course, how does it might reflect not only visual, but also disability in general, the neurological disability of our patients? I think these are some really interesting questions, and I'm sure we're going to hear a lot about them, but I think that I will stop now and ask you again, what do you think from what you experience in your daily routine, from what you have heard about the method, just before listening to our speakers? Do you think that OCT could be indeed a tool that can be now used to follow up our MS patients? Let's vote. I think the time is over, if I understand it correctly. No? No? Okay, but still the difference is not so large, so I'm sure that the discussion will be interesting, and I'm curious to see what happens after. So if the voting is over, I think we can go on. No?